Hello everybody, this is Dr Taneri speaking from Münster, Germany, and I would like to talk to you about our clinical outcomes with two different phakic IOLs, the IPCL and the ICL. The first phakic IOL implanted in the posterior chamber was presented by Fyodorov in 1986. The most popular phakic IOL today, the Visian implantable collamer lens, or ICL, is based on this original design. The ICL may be regarded as the gold standard for posterior chamber IOLs in phakic eyes because of its proven safety and efficacy. Oftentimes the term ICL is used synonymously with phakic IOL implantation. However, there are at least 3 other models available, one of which is the IPCL. The ICL has been around since 1993 and the current version has a hole in the center which is called aquaport and has been available since 2012. The range is from +10 to -20 diopters with up to 6 diopters of toricity. In the last year it got the CE mark, but it is not commercially available in a presbyopic version yet. In contrast, the IPCL has been available since 2012 and has a broader range from +15 to -30 diopters with up to 12 diopters of toricity, and it has multiple near adds for presbyopia correction. Both IOLs discussed here have a hole in the center of the optic and some holes in the haptic through which aqueous humor can flow into the anterior chamber. So the design is very similar. And we wanted to compare our results with the IPCL with those that we obtained with the ICL. In terms of surgical behavior, both lenses behave very similarly. The insertion process is absolutely comparable with both IOLs. However, the IPCL insertion is much easier than the ICL insertion. You don't need dedicated instruments. The IPCL can be inserted into the cartridge like you would do in a cataract IOL. And the cartridge has a simple but foolproof design, and the shooter is very easy to handle. This is a presbyopic version of the IPCL. You can appreciate the diffractive optics These are post-operative findings at the slit lamp and on the OCT, where you can see the central hole with a almost two flat vaulting. The IPCL toric has some markings, as you can appreciate, in the center of this slide, and the presbyopic version has a three-focal optics with these rings as depicted on the right side. So coming to the actual clinical results, here you can see our 3-month outcomes of those eyes that were targeted for plano. Looking at the uncorrected visual acuity after 3 months, in those eyes with plano target, we found more than 90% within 1 line of corrected visual acuity pre-op with both models. Moreover, a similar number of lines of corrected visual acuity was gained with both IOLs. Regarding spherical equivalent refraction, we observed an excellent correlation with both IOLs up to approximately 20 diopters of myopia. More than 90% were within 1 diopter of the target refraction with both IOL models, and the results were stable up to 1 year follow-up. Similarly, the results for astigmatism correction are equally excellent with both models. Here is a list of all adverse events in the last 10 years. There was a more frequent need for a secondary intervention after IPCL implantation, mostly because of a rotated toric IPCL. Cataract occurred twice after IPCL implantation and 4 times after ICL implantations. However, the ICL implantation have a longer follow-up. The vaulting was perfect in all of these highly myopic eyes, and cataract formation seemed to be age and myopia related rather than caused by these phakic IOLs. Two years after implantation of the IPCL or the ICL, we observed no significant endothelial cell loss. Similarly, both IOLs behaved comparable in terms of intraocular pressure up to 2 years. The pressure spike on the day of surgery is caused by retained viscoelastic material in the eye, which we now avoid with the use of HPMC. And there is no pressure rise up to 2 years on average. So in conclusion, we found equally good visual and refractive outcomes with the IPCL compared to the ICL in high and moderate myopia with and without astigmatism. There is no need for nomogram adjustment when transitioning from the ICL to the IPCL. However, a longer follow-up is warranted to determine stability of results and possible long-term adverse events, especially with the IPCL. Coming to an end, the IPCL is a very promising alternative to the ICL, especially in presbyopes. Thank you so much for your kind attention. Thank you so much for your kind attention.